I'm supposed to talk on regional anesthesia procedures for diabetic foot surgery. Well, surgery procedures for diabetic foot can be carried out under both general and regional anesthesia. But owing to the frequent comorbidities associated with diabetes and the frequent old age of the diabetic patients, regional anesthesia is usually preferred over the general anesthesia because of the associated side effects of general anesthesia, which are slightly on a higher side as compared to the regional anesthesia. Now, in the regional anesthesia, we have spinal or epidural anesthesia along with the peripheral nerve blocks in the form of ankle block. Spinal anesthesia usually gives a good anesthesia for conducting various procedures like debridement or amputation for diabetic foot. But side by side, it is associated with sympatholysis giving rise to hypotension, which is a frequent complication or side effect associated with it, especially in diabetic patients, which are in which there is a component of peripheral neuropathy. So peripheral nerve blocks in the form of ankle blocks are preferred over spinal anesthesia. One, because of less side effects associated with it, and second, because of it's technically very easy as compared to the spinal anesthesia. So before starting, let us quickly go through the nerve supply or the sensory sensory supply of the foot itself, which is helpful in understanding various nerves which we usually target for various foot surgeries in cases of diabetic foot. So foot is basically supplied by 5 nerves, and 4 of these are branches of the sciatic nerve, and 1 is from the femoral nerve. Now, the sciatic nerve branches, the common peroneal branches are superficial and deep peroneal. The superficial peroneal nerve supplies the dorsum of the foot. Superficial peroneal nerve supplies the dorsum of the foot, and the deep peroneal nerve supplies the first web space. The branch of the tibial nerve, that is the posterior tibial nerve, supplies the sole of the foot with different branches, and the sural nerve supplies the lateral side of the foot. Finally, the femoral nerve branch, that is the saphenous nerve, it supplies the medial part of the foot or the medial malleolus and the medial part of the foot along the medial arch of the foot. So this is about the nerve supply. Now, regarding the nerve supplying the bones, the plantar surface is basically supplied by the posterior tibial nerve, and the dorsal surface by the deep peroneal. So all the nerves which I have already discussed regarding the sensory supply, 2 of them are supplying the plantar and the dorsal surface. So whatever nerves we have discussed so far, basically these nerves can be blocked by 2 approaches, namely popliteal block or the ankle block. In the popliteal block, we basically block the sciatic nerve branches in the area of the popliteal fossa. And in the ankle block, we target each of the 5 nerves which I have described individually around the ankle. And the important difference between these 2 approaches is that with popliteal block, the calf muscle paresis is there, so that after the procedure, patient may have impaired mobility after the surgery. While in ankle block, this is very minimal because most of the muscles which might be blocked are the peripheral ones. So patient doesn't feel too much of difficulty in walking. And also it is technically easier to perform, though these are the 5 nerves which we have to block individually. But technically it is much more simpler as compared to the popliteal block. So I shall be discussing the ankle block itself. So once again, regarding the nerves which we are going to block, 3 nerves are over the dorsal aspect of the foot. These are the superficial and deep peroneal nerve and the saphenous nerve. And 2 nerves are in close relation to the Achilles tendon. That is the posterior tibial nerve and the sural. Now, the important landmarks which are useful while giving this block, these are the medial and the lateral malleoli, and the intermalleolar line. Then there is dorsalis pedis artery, which lies medial to the external hallucis, extensor hallucis tendon. Then another landmark is this Achilles tendon. So starting with the deep peroneal nerve, well, a deep peroneal nerve lies lateral to the dorsalis pedis artery over the dorsum of the foot. And it supplies web space of the between a first web space between the first and second toe. So to block this nerve, the site of needle entry is lateral to the dorsalis pedis artery. Needle is injected and we hit the bone, we withdraw and give around 5 ml of local anesthetic. Well, this block can also be performed under ultrasound guidance, and the ultrasound probe is placed between the two malleoli, and we identify the dorsalis pedis artery over here. And lateral to the artery lies the nerve, and here we inject the local anesthetic. So this is how we perform the deep peroneal nerve block. Then the posterior tibial nerve block. Posterior tibial nerve lies behind the posterior tibial artery, midway between the medial malleolus and the Achilles tendon. So this is a useful landmark, and it supplies the sole of the foot, while its branches, namely the calcaneal nerve, medial and lateral plantar nerves. Now, in order to block this posterior tibial nerve, the site of needle entry is a point between your medial malleolus and the Achilles tendon. Here, the needle is entered and we inject 5 ml of the local anesthetic, and another usual landmark is the posterior tibial artery, because our nerve lies behind the posterior tibial artery. So the point of entry is midway, and we also feel the sensation of the artery, and behind the artery sensation, we inject the local anesthetic. Under ultrasound guidance, we place our probe between the malleolus and the Achilles tendon and identify this posterior tibial artery, and behind the posterior tibial artery lies the nerve, and around the nerve we inject the local anesthetic. Then this superficial peroneal nerve, it's a subcutaneous nerve which lies along the lateral malleolus. It becomes superficial around 10 to 12 centimeter above the lateral malleolus. So, and it supplies dorsum of the foot, except the web space between the first and second toe. So, in order to block this nerve, kind of a subcutaneous infiltration is done above the level of the lateral malleolus from anterior to posterior. 5 to 7 ml of local anesthetic is injected. Now, this local anesthetic can also be injected at a proximal level, and this is usually done more easily under ultrasound guidance. Approximately 10 to 12 centimeter proximal to the lateral malleolus, we place our probe like this in a transverse fashion, and in the subcutaneous plane, we identify the nerve and infiltrate local anesthetic to block the nerve. Saphenous nerve is easier to block because of its anatomical location. It lies close to the saphenous vein over the medial malleolus. So, and it supplies the medial part of the foot along the medial arch and also the medial malleolus. And the site of injection lies above the medial malleolus, and in a subcutaneous fashion, 5 to 7 ml of local anesthetic can be injected along the greater saphenous vein over the medial malleolus. Well, this can also be done under ultrasound guidance, where the probe is placed above the medial malleolus, and we identify the vein, and side by side lies the nerve. And alongside the vein, we inject the local anesthetic to block the nerve. Finally, the sural nerve. The sural nerve lies between the lateral malleolus and the Achilles tendon, close to the small saphenous vein. Well, it supplies the lateral aspect of the foot. And the landmark for the site of injection is between the Achilles tendon and the lateral malleolus. And since it lies subcutaneously, not underneath the deep fascia, we inject local anesthetic in the subcutaneous plane. Around 5 ml is sufficient. Under ultrasound guidance, the small saphenous vein identification helps us to guide us to inject local anesthetic besides the vein. So this is how 5 nerves are blocked. I will give a summary of these in the end. But beforehand, I would like to also discuss lastly the role of lumbar sympathetic block, because all these patients with diabetic foot have got pain, paresthesia, burning sensation in the distribution of their foot. And usually it is one of their prime complaints which hinders the mobilization and healing of their wounds. So we prefer to do lumbar sympathetic block while the patients are being managed, because it helps in decreasing the sympathetically mediated pain, and it also improves the wound healing by improvising the vascularity, which might be there. So in this way, it was useful. So regarding the local anesthetic, which we should choose for performing the block, because usually we require 20 to 30 mL of local anesthetic for blocking these 5 nerves around the ankle. So we have on one hand lidocaine with us, which is which has got quick onset and somewhat shorter duration of action. And we have bupivacaine and ropivacaine with us, which has got a somewhat longer onset and also the longer duration of action. Among this, ropivacaine has got a longer duration and also quicker onset, so it is preferable. And if we look like 0.5% of ropivacaine and 0.5% of bupivacaine, approximately 25 to 30 mL in safe, as if we look into the adult population having a body weight of somewhere around 50 to 60 kg. Now, if we have only bupivacaine with us, so we may combine 20 to 25 mL of bupivacaine with 0.5% with 10 mL of lidocaine, so providing both the quick onset and the longer duration of action. So to conclude, we have 5 blocks with us and we have got 5 sites. So first site is between the 2 malleoli, between the lateral and the medial malleoli. Then we have 2 sites which lie between both malleoli and the Achilles tendon. That is, one between the lateral malleolus and the Achilles tendon for the posterior tibial nerve block, and for the sural nerve block between the lateral malleoli and the Achilles tendon. And finally, we have 2 blocks, that is for the saphenous and the superficial peroneal nerve block. We have to provide, we have subcutaneous infiltration above the respective malleoli. So 1 between the 2 malleoli, 2 and 3 between the Achilles tendon and the malleoli, and 4 and 5 over the malleoli in a subcutaneous infiltration fashion. That's all from us. Thank you.